All right, I have 5:01 here on our time, so I think we'll go ahead and get started. First of all, thanks everybody for joining. We have already a bigger crowd than I was expecting given the date. I know several folks that I spoke with are traveling today or out, so thanks everyone for joining. And yeah, if you have a question throughout and want to put it in the chat box or notify me of some way. I will try to, hopefully I can see it or somebody can let me know. So we're going to talk about imaging of the spine. Welcome to 2025 and another year of Virtual Global Spine. Um, this is a talk that different parts of this I've talked about at different times, and it's near and dear to my heart, something I'm very interested in. Disclosures, nothing relevant to today's talk. So this is something that over the last 4 or 5 years, we've done several papers and presentations, both at radiology meetings, podcasts, etc. And I always think it's interesting to have colleagues in different fields where we overlap. And so I've learned a ton about what I'm going to talk to you about today from my radiology colleagues. And it's always interesting to kind of hear where they're coming from and their perspective when they talk about different parts of this today. So we're going to talk about what imaging to get for a variety of different things, and why we like plain film so much. And that's certainly something I'm going to spend a lot of time talking about tonight. And then we'll end the talk by talking about what makes a good film or what makes a good image. All right, so what imaging to get and why do we like plain films or x-rays so much? Well, I would say that I think plain films or radiographs are perhaps the most important imaging in spine. And you might say, well, what about CT or MRI? And I certainly would give you that they're incredibly good, and in some ways they're better, which is obvious, I think, right? There are things that we do in spine that without a CT or an MRI, we wouldn't be doing them, or we couldn't do them at all. And so I hope to make the point that they're just different, and they're good at different. They're good at helping us with different things as we image the spine. So this doesn't have to be told to this group here, but obviously MRI is very good for things like looking at stenosis, right? And so here on the left, you see soft tissue really well. You see the spinal cord has areas of compression at multiple levels. You see it looks like there's some cord signal change. You see great visualization of the discs and the herniations and the disc bulges present. On the right, you can see a good example of an epidural abscess. Obviously, something that wouldn't be possible without MRI. So MRI is certainly very good and really the backbone of a lot of what we do. There's no doubt about that. CT also has a lot of great things that it does, as you're well aware. It's great at showing you bone, particularly if you're worried about whether something's fused, whether you have a non-union. It can be good if you're looking for broken hardware. Although sometimes x-rays are easier for broken hardware. And so here you see a case we did recently. I've just changed the windowing on the bottom, but there was a crack through two of the screws right at the head, and there was a non-union. And you can see that discontinuity if you look closely and you changed the windowing to get some of the artifact out, but you could see it a whole lot better once the patient stood up and this separated, the screw head separated from the screw a little bit. So again, they're good different things and for different reasons, which is what we're going to see today as we go through some of these cases. So CT and MRI are really good. There's no doubt about that. In fact, my specialty is spinal tumors, and so it's really the backbone of a lot of what I do, right? When I work up an unknown lesion, it's critical that we have an MRI of the entire spine. We have a CT of the area of interest as well as the chest, abdomen, and pelvis. When we look at tumors themselves, and so here's a table of just some of the common spinal tumors. You'll see that when we talk about the characteristics typical of different things, we're oftentimes talking about the imaging, right? And so particularly with some of the benign tumors shown the bottom half of this chart, some of those characteristics may change whether we're even getting a biopsy or not. So I do think it's important that you understand what you're looking at with some of the advanced imaging, particularly in regard to tumors, because it might change how you, or it is going to change how you do things and how you approach it. So I think we should go through a few of the very common kind of back to basics things with imaging with some of these tumors in terms of CT and MRI before we move on to talking more about the plain films. And we'll do that with cases. And so here is a case of a 16-year-old, months of back pain, worse at night, NSAIDs help. And if you look at this, what you see is that if you just start over here with the MRI, you see that there's lots of edema in the area, lots of fluid signal. If you look at the CT, you'll see the location is in the posterior elements. You see there's a lot of this periosteal reaction, this area of central nidus, lots of things you couldn't pick up from a plain film, obviously, although there does appear to be a bit of a scoliosis possibly related to this. And so, this is the classic look, classic characteristics of an osteoid osteoma. And this is something that at our place, typically MSK-IR will treat. We typically don't operate on these as much anymore now because of the different things they do. Another classic thing you're going to see is the classic hemangioma. And so if you look at this L3 vertebral body here, the classic hemangioma is bright on T2, it's bright on T1, and typically is located in the vertebral body. And then if you look at the CT, it has a classic appearance. And this is something that's oftentimes tested on boards and in training exams. And that is that channeled appearance, or that honeycomb appearance, it's sometimes called, that you can see on the coronal, sagittal, and even on the axials, you can see it. So this is the look of the classic hemangioma. Well, what about atypical hemangiomas? Well, the word atypical in regard to hemangioma is used for really two different things in the literature. The first is to refer to a hemangioma that is aggressive or breaking through the cortex. When there's cortical breakthrough, you'll see people use the term atypical hemangioma. The second is when they refer to a lipid poor hemangioma, or in a hemangioma that's bright on T2 and dark on T1. Right, because it's lipid poor, it doesn't show up on the T1 as well. And they're used both ways in papers that you'll see. And here are just some different examples of that, right, of bright on T2, dark on T1. You see here there's a lot of cortical breakthrough of this one. Again, here, dark on T1, bright on T2. And it matters because, as many of you know, this is oftentimes the look of things like metastatic disease, where it's dark on T1 and bright on T2. And so oftentimes you're either following it up with imaging or you're getting a biopsy, depending on the situation. And you're still operating for the same typical things: cord compression, instability, right? And so here you're looking at a case of a patient with an atypical hemangioma. They were myelopathic. And so you can see there's cord compression. And so this patient underwent a preoperative embolization, which would be what I would say is pretty standard for any hemangioma, because it's going to be vascular and bloody if you're going to operate on it. And in this case, an intralesional resection is appropriate. I put on here en bloc-ish, and that's because oftentimes if you can do a en bloc-ish, en bloc meaning in one piece surgery, then you can keep the bleeding down some. So in this case, I think we actually came in around it and just cut this at the base and pulled this all out as one piece to decrease some of the bleeding. But again, it's not for a margin in this case. And here's the plain film afterwards. This patient's years out now. It's done great. So different case, just to show you some more examples. This one shows up better on the plain film, as you can see. So T12 lesion, you can see there's been collapse. It's a young female, 18. She's got debilitating back pain. It's now getting worse. And you can see that it's an atypical hemangioma. It got biopsied. That's what it came back as. And so she underwent a similar type of course, right? She underwent preoperative embolization and then got treated surgically. And in this case, there was no en bloc-ish type of procedure. right? That would have been unnecessarily risky given the great vessels in front and the extracortical disease or extracortical parts of this one. And so in her case, she underwent a corpectomy to correct her alignment in both planes, and she did very well. Now here she is a year post-op on her upright images, and remains intact, back to kind of doing all the things she wants. And you can see one of the advantages of the CT here, right? She ended up getting a CT, and you can see she actually fused through her cage, which doesn't always happen, but you certainly want this to happen in these cases. And so again, another great example of use of CT, in this case demonstrating that she has fused well here. So here's another case, 26-year-old male. He's hyperreflexic, myelopathic, and in this case, he's got a pretty classic looking osteochondroma in the setting of MHE, multiple osteochondromas. And so here you can see on his MR and his CT, some of the classic things. I could have given you a better cut of the CT probably, but the typical osteochondroma has continuity between the cortical and intramedullary space throughout the lesion. And you can see here there's a good deal of cord compression, right? And so if you look at this MRI, this is actually the spinal cord compressed back here, and all of this other stuff is actually tumor. And so in this case, we do perform an intralesional resection because we're trying to minimize risk to the spinal cord. It wouldn't make a lot of sense to go trying to get all the way around this by the great vessels, etc., into the chest here. So we do actually go through the lesion after talking about the cartilage cap with our radiology colleagues, whether there was really much of one at all or not. And so here's a little bit of what that looks like. We use that advanced imaging to generate our 3D model. So another great use of some of this advanced imaging. And so here you see I'm just overlaying it on the image there. This helps us plan our cuts and plan how we're going to pull things out safely. Here you see the pre and post images, and so this is done with my colleague from neurosurgery, Dr. Molina. We do all of our really primary or en blocs together, which has just made a world of difference. And so here you can see we've made a pretty big resection around this area. And we've now given the cord lots of space here. We've used a femoral allograft in the back that we've then shaped to the bone and put in graft around it, as you can see in these axial cuts. And here are the plain films postoperatively, and the patient's done very well moving forward. Another case of a classic image that you might see is this one. And so here is a case of a 16-year-old. He's got neck pain. He's actually got a palpable lump back there, which you can see on the MR. And if you look, this is located in the posterior elements of the bone. On the MRI, you can see that there's fluid levels, and this is really a classic look here. And on the CT, you can see it's expanded the bone and it's destroyed a lot of the bone, right? And so when you put all these together, this is a really classic appearance of an ABC, right? And so this gets a biopsy, and it comes back as an aneurysmal bone cyst. Aneurysmal bone cysts, of course, are benign aggressive lesions, and so they will recur and they'll eat up bone. And so if you can do it en bloc, that's great because you can reduce the recurrence rate, but sometimes that's not possible. And so there have been lots of studies that we're not going to go through here, looking at serial embolization as a method that can be effective for treating these. They've looked at places where they do gross totals and don't do any en blocs. They take them all out, gross total. Here's one example where only 4 of them had recurrence, and those all got a reoperation that then stayed gone after that. And you've seen combinations of that in the literature. So lots of stuff has been tried. It seems like most people agree that if you can do an en bloc, that's great. You can reduce the recurrence rate. But that needs to be weighed against kind of what the safety is in the local anatomy, right? Which is different than say, more malignant things that we treat. And so in this case, we talked to the parents, healthy 16-year-old male. This thing's abutting both vertebral arteries. And so we told them, look, we're going to do it in an en bloc manner, meaning we're going to get all the way around it and take it out. But I would be prepared for some residual around the back of that vertebral artery, because we all agreed we did not want to end up getting into one of his vertebral arteries for this lesion. So we sent them to get embolized first. And again, any of these vascular lesions, hemangiomas, ABCs, et cetera, you want to get them embolized before. And we have a fantastic neurosurgery interventional group here, which I'm showing in the upper right here. These guys have just been fantastic in embolizing these, and it pays off big time to have a group that's good. It makes a huge difference in surgery, and really a credit to the. I always tell the patients too afterwards that we'll end up barely losing any blood, and oftentimes it's because they've done such a good job on this. In this case, because it's a cervical lesion, it's sometimes hard to embolize vessels depending on where they're coming from and where they're going. They worry about embolizing, obviously critical vessels. And so, one thing you can do in place of or in addition to is what you see here, which is direct embolization as well. And so, here they've done both of those as a way of reducing blood loss in these. And this patient, underwent an en bloc and actually had negative margins. It peeled off super nicely the back there and has done quite well. All right, similar case here, just to drive home the point. 19-year-old, leg and back pain. Again, posterior elements. Here I've put a little location cheat sheet for some of the things that are commonly in the posterior elements, commonly in the vertebral body, right? And so ABC is a common one you'll see in the posterior elements. So posterior elements, fluid levels. The CT shows an expansile destructive lesion, excuse me. And it's worth pointing out here, our friend, the plain film, does show us that at this area of L1, we're missing a pedicle. So, if all you have is a plain film, you can certainly tell that something's going on here that you want to figure out what it is, even if you don't have the advanced imaging. So similar to last case, get the team back together, kind of rinse and repeat here. So get a biopsy. It's an aneurysmal bone cyst. We have a 3D model made, and then send them for embolization. And this got removed en bloc as well. And so again, we've done a similar reconstruction in this case. We've used a femoral allograft in the back, and there you can see our resection of the specimen. And again, postoperative CT, you can actually, another good use of this postoperative CT is not only looking at your graft, but looking at your osteotomy. So here you can actually see our osteotomy cut through the bone. And this is actually graft that we've then packed it with after the resection, excuse me. And again, the advanced imaging postoperatively in terms of the CT has been great in demonstrating that a lot of these grafts we use end up fusing. And that's something that we probably didn't appreciate before. I would always say, well, these allografts are structurally great, not sure they ever really fuse. And we've had, numerous patients now that go on and have these fuse long term, which is good. Advanced imaging, of course, everyone knows is great for malignant lesions. That should not come as a surprise to anybody. So here's a case of a 67-year-old with a chordoma. You can see in the front here, it's extending from 3 down to 5. I'm not giving you the best image here. I apologize for that. But in this case, both vertebral arteries are involved. So here's a look at the CT angiogram. Here's the main area of interest. And I'll tell you, it wrapped around both vertebral arteries. And so that did present some challenges as to how we were going to treat this. A little bit beyond the topic today, but in terms of imaging, I'll show you some of the images and talk about what we did. So we went in the back first, removed the posterior elements, freed the vertebral arteries and skeletonized the roots, and then came back in the front for the en bloc resection and the reconstruction with the femur. And so again, in terms of imaging, the CT is really great postoperatively in these because you can see exactly where you put the bone, how you shaped it, and at some point in the future, when you have things like this, you may have to re-CT to see if it's fused or to see what things look like. But again, the plain film shown here is going to show you the whole picture all at once, and that's something we're going to talk about moving forward here. And there's just an intraoperative picture. So there's no doubt MRI and CT are fantastic. But I think it's critical to understand that they do not replace obtaining and understanding how to evaluate plain films, right? They give you different information. and they help you with different things. And so, one of the first things we did this podcast several years ago now was in response to, when you're in training, you're constantly asked by other services, well, why do you want a plain film? We already have a CT or we already have an MRI. And numerous times we are explaining that it's a different study, and it gives us different information, as many of you know. And so another thing with films is, I tell our floor staff here, our MPs, our PAs, our residents, that plain films everyone should be looking at and evaluating, right? So if I'm stuck in a 10-hour case, and a patient has their films done, I would like the other providers to look at the films, certainly assess them for quality, whether it's an adequate film, whether there's any obvious complication, and make some decisions, right? Those decisions might be as simple as, oh, this isn't a good film. Let's send them back down to X-ray and get the right film. Let's get a lateral. They got some sort of oblique here, or they didn't get the area of interest, right? And so I think everyone can make those. Not everyone. I think providers can make those decisions. They don't necessarily need me for that, right? But that happens a lot where somebody gets a film and then it's the end of the day, and I go, oh, did anyone even look at this? You guys know this isn't a good film. And so I do think it's important that everyone gets in the habit of reviewing films and evaluating them critically. And we're going to go through some of the things here we're looking for. On the flip side, MRI and CT, it's great if everyone's looking at them. I do think it's more likely that the attending surgeon is going to make that decision whenever they can look at it, though, right? So when you think about the reason you're getting an MRI or CT, those are things the surgeon's typically going to make the decision on. Is the patient going back to the OR? Is there a post-op hematoma? Is there compression on a root where you thought you had good decompression? Is there a complication with the bone graft, et cetera? Is the foramen looking narrow? When you get an MRI, what are the limitations? Well, certainly MRIs have limited value if they're not correlated with clinical symptoms. And this dates back to the 90s, and this paper by Scott Bowden and other work that's been done showing that folks that are asymptomatic, if you get an MRI, you're going to find stuff. And they might not have any symptoms or any deficits, right? And so we'll go through this a little more in a few cases, but disc bulging, loss of disc height, even major herniations are all part of aging, whether we like it or not. MRI may also have limited value when you're following discitis, right? This comes up all the time, and it's in the infection talk that I give. But discitis, the MRI takes many months to change, and so you might get an MRI of a patient with discitis. They might undergo treatment, and then somebody might get an MRI at 2 or 3 months and say, "Oh my gosh, it looks the same." They're failing, and that's absolutely not true, right? They're failing if their CRP and their labs are going the wrong direction, if clinically they're going the wrong direction, if they develop an epidural abscess, if they develop a new neurologic symptom, those are failing. But the MRI itself typically looks the same, 2, even 3 months out, and it's going to take several months before that starts changing. And then MRI can have a lot of limitations post-operatively, and so there's always going to be fluid after you operate, right? And so, just go ahead and expect that it's going to get read as post-operative fluid cannot rule out infection or something like that. And that's it's just something to expect. If you're using metal, there's going to be artifact. How much depends on the type of metal, obviously, and what type of surgery you've done, but expect there to be some artifact. Even with those limitations, there's still times that you're going to want to get it post-operatively. And so my example is if a patient wakes up, they're not moving their legs, you should probably get an MRI. Right now, depending on the circumstance, you may get a CT, you might get an MRI, there's different things you may get, but there are times when you want to get it, even though you know the limitations. And so an example of that would be this patient. This is a patient who was 6 or 7 weeks out after their surgery. They had thoracic myelopathy. They had a catastrophic failure distal to their implant, had a lot of back pain. We admitted them that day, legs were still working, and I said, let's admit them, get the imaging, and go to the OR. And in holding, he says very nonchalantly, hey, when I was in MR, my legs stopped working. And I said, what? And they were working again in pre-op. And his wife said, you didn't say that. And he said, yeah, I didn't really tell anyone. And so, this is going to be a problem, right? And so sure enough, we get neuromonitoring data before we even move them just once he goes to sleep, and as soon as he goes to sleep, there's no motor data. And so we actually wake him up then, because I know his cord's sensitive and he can't, we get him fully awake for a wake up, just can't move his legs. So I call the family, I tell him, I say, look, we still need to stabilize this, we still need to proceed. And we did. And afterwards, he doesn't move his legs after either. But while I was in there, I also ultrasounded. I could see that we had things nice and open. Canal was open. And I said, well, to be safe, let's send him to get an MR tonight. And anytime I do that in someone who has some issue like this, or I guess anytime it's happened, I recommend talking to the radiology attending and making sure you agree, right, on what you look at. And so I talked to the radiology attending who says, well, I think there's a new piece of disc in the canal. And they draw an arrow and they say here. And so I'm on the phone at 2 or 3 in the morning saying, well, look, this looks like this is inside the dura, if that's what that is, right? Here's spinal fluid, here's the cord. And I said, plus it's midline and there's no correlate on the axials. It's a little washed out, it looks like here. And so we went back and forth, and I was explaining that, well, if we really think this is something, we're talking about going back in the operating room. And so we eventually settled on me saying, look, I don't think this is real, and her saying, well, we do have a better scanner that we can put, because I said, look, there's a lot of artifact. There's not a screw in the cord. We know this is all artifact. And so she said, well, there's a better scanner. We can get them on. Let's send them back. And so we agreed to that. And sure enough, there was, with better metal reduction, better imaging, everything was wide open here, just like we saw in the operating room. So you just got to be aware of the limitations. Got to be aware that things might get said, and you have to kind of address them as they come along in terms of things like this. Not correlated with clinical symptoms. This is something that's come up numerous times. It's a fun topic to talk about, particularly with radiologists, because you can talk about what all needs to be in the report. And this is something we've had different symposia on over the years. And this is kind of the example of someone will come in, 61-year-old, BMI is 48, back pain, and their MRI looks fine, right? There's some loss of disc height and some disc bulging, but no high-grade stenosis anywhere. And they want to talk about all the things that are wrong with their back in this big report they have. And so it's important to counsel these patients, obviously, about some of the work that's been done. This is the Bowden paper, for example, where they looked at patients with no symptoms. And as you got over 60, you had lots of different things show up, right? And even once you're getting into, in the 20 to 39-year-old group, a third of them had bulging disc and disc disease. So it's important to remember that changes in your spine on the MR are actually part of life. They may or may not be symptomatic. And so here's another one. Guy comes in, full spine MR. He's got a question about what they're saying in his chart, and you open up his read, and this is the read. And this one kind of threw me for a loop, because I could not believe there was so much to write about this MRI. And so I had to ask my colleagues, like, do you guys get paid by the word, or how does this work? Because it was really and he wanted to go through every part of it. So it is a topic that's probably we'll continue to discuss in terms of how much should be in these reports and how they should be organized. That's a different talk, but just understand that's obviously one of the limitations. What else? CT limitations with CT. Well, in terms of postoperatively, the CT can be pretty good. You can look at, if somebody comes in a few weeks out, maybe something looks like it's not healing very well. You can look for air tracking deep. Is it a superficial issue, or is it something that's tracking all the way down? Obviously, CTs for PEs in somebody who's post-op with pleuritic chest pain, shortness of breath, new O2 requirement. Again, looking at hardware, bone graft, your osteotomy cuts, or even looking at the foramen if they have a new radic post-op, all very helpful for these things. All right, so here's an example. Here's a patient who comes in with a deformity, undergoes a surgery, does very well, is very happy, is walking around, but over the first few weeks says as she's left the hospital, she's got, this burning L3 radicular type pain. And so we get a CT, and sure enough, you see that at L3-4, I have not removed that facet. And so you can see as I've done the ALIF and corrected her, that I've probably pinching that nerve there. So sure enough, we took her back and cut the facet off, and all the pain went away. And so again, CT can be incredibly helpful for things like this postoperatively and give you a great look at where the issue might be. All right, all of that to get to the almighty plain film. So plain films, or some people would say x-rays, or some people would say radiographs, but we're all talking about the same thing. I have to put in a picture of Dr. Laura Randall, who's the chair at UC Davis now, because he was one of my mentors at Utah and a good friend of mine. And it used to bother him when people would say, I looked at the x-rays, because he would point out that, well, you don't look at x-rays, right? X-rays are not visible things you see. You might have looked at the film or the radiograph, but nonetheless, we're all talking about the same thing. So you'll see those used interchangeably, whether they're correct or not. So why do we like plain films? Why are they so helpful? Well, there's several reasons for that, and we're going to go through some examples of each one. One reason is you can see the whole picture at once, right? And so if I were to show you this picture of a room, you would see a good bit of detail. You can see there's a washer and dryer, it looks like, and a sink, and maybe a tile floor, but you would have very little idea about what type of house this is in. Maybe it's not in a house, maybe it's in a big house, maybe it's in a small house. But if I wanted to know about the house, this isn't going to tell you very much about the house despite the detail. But if I show you a picture of a house, well, this tells you a lot about the house, right? It tells you roughly the size. It tells you that there's land around it. It looks like a good sized driveway. There's a lot, you can imagine there's probably a couple bathrooms in here, a couple bedrooms. You can see the whole picture at once. You can kind of get an idea of what you're dealing with all at once. And I'd say that's similar to when you're looking at plain films, right? The CT is like, or an MRI is like looking at that close up of the room. So here are some CT cuts, and you might see some very fine detail here about how maybe there's some bony ingrowth here, where the screws go. It looks like this is probably a pelvis, I'm guessing, and a spine, but you have very little idea about the whole picture. And if I back up and show you a film, you immediately can see the whole picture and can see there's been a big bony resection here. Looks like there's a bone graft in the back. You can see all the metal that's in the picture. You can even see things like staples in the skin, etc. So it gives you the whole picture at once. Useful not only for organizing your thoughts if you're evaluating a patient, but also useful in conference, right? You want to put up a picture so everyone knows exactly what you're talking about to put up the plain film. In clinic, a patient might come and see you with back pain, and in this case, deformity, and they ask about surgery. Well, you look at their plain film and you're going to get a lot of information right away, right? And so in this case, you see this patient, you right away know a lot about this patient. You know that they have multiple compression deformities throughout their spine. Looks like they've already had some cement put in one of the levels. So you know their bone is of poor quality. You can see that the density of the bone is not that different from soft tissue. And so you already are getting a good look at the whole picture, and you already know this patient's probably not going to be a great candidate for a deformity type surgery. Here's a patient who comes in with an MRI, right? And their legs are going numb, they're weak over the last several days, and they have this mass in their spine. And so this is one you're going to have to deal with probably because they're losing function, right? But again, you don't know what the big picture is. And with the plain film, you immediately go, oh, okay, well, L2. Great. It's right in the middle of this curve down here. There's also this thoracolumbar kyphosis. And so there's a lot of things here that you can see. Let's see. All right. Just looking at the chat, I have a little notice here. Okay. There's a lot of things you can see here that immediately give you information about the surgery that you really need to know before you start. And so you know going in that this patient, I didn't tell you this, but they can't handle a really big surgery. And so you got to figure out how you're going to deal with that curve, right? And so this patient does undergo surgery, and it's a careful balancing act of us telling them, look, we don't like stopping around this thoracolumbar kyphosis. We're going to try to contour it and do other things to prevent failure here. But it gives you all the complete picture at once. Very, very useful. What about this patient? 52-year-old female, HIV positive, Hep C, has radicular pain, is here for an ACDF at a single level, C6, 7. Didn't get plain films after the last visit. She was supposed to get them on the way out and didn't get them. And in pre-op, it's noted that she's got marks on the front of her neck. And so we said, well, let's get your x-rays done before we go back there. And I'll give you a second to see if anyone notices anything about this AP image of her neck. So if you look closely, if anyone's had a chance to look here, you'll see that she's got these radio opaque lines on both sides of her neck. And so coupled with the tracks on the front of her neck, she was a former IV drug user many years ago. She's a normal functioning member of society now and had broken off needles in her neck. And we wouldn't have known that had we not gotten that plain film. We actually saw these and asked her about the marks again and said, hey, have you ever broken off needles in your neck? And she said, oh yeah, years ago when I was, I think in her teens. And so, if you're going to do an ACDF, C6, 7, that's right where your blunt dissection is, either side, right? And so we would have been in a lot of trouble with this patient had we not. So surgery was canceled. I think we offered her a posterior surgery, but really important reason to get plain film. See the foreign objects or foreign bodies that are in the tissue. Plain films are also easily repeatable, particularly not just in clinic, but in the hospital. And so here's a case where somebody undergoes a corpectomy, and oftentimes we talk about the soft tissue and the swelling that should be at C2 or C6, so 6 at 2 and 2 at 6, so 6 millimeters at C2. So here's pre-op is normal, post-op there's swelling, which is also normal, but then a few days later it's back down to normal, which is kind of what you would expect. And so maybe the drain clogs, maybe they're saying they're having trouble swallowing. And one thing you can always do is do serial imaging of lateral C-spine films, for example. All right, we haven't said much about how the films are done. And so we're going to spend a minute here and talk about the importance of them being upright. And so here you see a patient, we're going to fly through some of these examples, who has a okay looking MRI, CT, there's not a lot there, maybe a little gas, a little vacuum phenomena at 5-1 here. And yet when they stand up, you can see there's a pretty marked slip of 5-on-1 here. So a big difference between them lying down for the CT or the MRI and them standing up. And so this is the patient who was symptomatic, underwent fixation and did very well after that. Here's a case of a lady who underwent a surgery for this level, did well initially, but then was having excruciating pain about 2 months out. And these were you see the labels up here, it kind of gives it away, but these were uprights, and we kept looking at them going, I don't know, these look okay, and yet she's still having a lot of pain. Well, it turns out her uprights were actually lying down. She'd been talking to the techs and saying, look, it hurts too much to stand. I know they're supposed to be uprights, just get them, me lying down. And so once we finally learned this, we sent her back to get real uprights, and you can see it was pretty dynamically unstable, right? And so if you just look at the end plate below, she'd actually cracked her pedicles at the lower level. And so every time she stood, she was kind of levering forward. And so we fixed her to that lower level, and she did great after that. Again, more pictures here, plain film and CT. You can see a lot of gas at that 5-1. And when this patient, they said, well, I can't stand up, it hurts too much, but they were intact. We said, well, let's use a walker and have you at least kind of get upright so we can see what things look like. And you can see there's a dramatic shift in that 5-on-1. So big difference whether patients are upright or not when it comes to this imaging. Same could be said for stability of different parts of the spine. And so here's a case of a young lady who has developed myelopathy and was having trouble with her hands at work. She's a lawyer. And what you can see is that she's got this osodontoid at C2 here. And as she flexes forward, you can see that interval opens up quite a bit, and you can actually see how far the posterior arch of 1 comes forward here, not leaving a lot of cord, not leaving a lot of room for her cord. And so in this case, she underwent a 1-2 fusion, and all the symptoms got better, and she did really well. And so, and again, you can use films to follow her in clinic. And so this is over that first year surgery, and then follow-up. You can see that by 1 year, this looks pretty well fused, especially if you look at all the different images. And then you can also have her flex, right, and see that things stay in place when she flexes and extends, and everything looks really good here. So again, very useful in follow-up in terms of using the plain films and following up your imaging. You wouldn't get a CT, obviously, over and over to look at these things. But plain films are very useful to follow patients in the clinic, as many of you know. All right, why don't we end with this case here? And so here's a patient who's here for a C5-6 ACDF. We're in the operating room. We've marked what we think our level is. It's not all the way down on the disc. I don't have that one saved, but we've marked here, at least for the incision, where we think we're going. And we're ready to proceed. And it says here marking C5, so it looks like we've marked 5. If you just quickly look at this, right, you guys can probably count this and decide what you think it is. But this was a real case when I was a fellow, and there was some argument about what level this really was. And luckily, we were trained to be pretty anal about everyone having a preoperative X-ray, and so everyone needed to have a preoperative X-ray. And the reason for that, or one of the reasons for that, besides some of the reasons you've already seen, is to make sure you know what you're going to look at when you're in the operating room, right? And so we'd already looked at this preoperatively and said, okay, when we look, there's going to be kind of an odd looking X-ray. And what we did is we then look at our CT and we compare it and we say, can we make sense of this? So in this case, you can kind of use all your different things. You can use your soft tissues and try to line up where the soft tissues are. You can use the morphology of the bone as you scroll back and forth and try to line those up with your levels. And you can also scroll out and look at your facets on each side. So in this case, this patient had this very abnormally overgrown facet on one side, which is what you're seeing here. And so this line is actually not a disc space, this is a facet. It just looks like a disc space here, but it's actually, this is the facet you're seeing. And so in reality, if you put double line, the double lines are representing disc space, this big circle is representing the facet. You can see these are the actual levels, right? And so here's 2, 3, 4, 5, 6. So the patient gets a 5-6 ACDF, which is right here. We would have been off by a level had we not gone through this exercise preoperatively. And so it's a great example of getting your film beforehand so you know what you're looking at intra-op. So to identify the correct level intra-op is one of the great reasons to have a plain film. So it says here all patients going to the OR should have a plain film even if lying down. That is mostly true. The times when I will not get one or maybe not get one is if there's frank instability. And so we had a patient with a 1-2 subluxation just 2 weeks ago and had them in sandbags and a sign. And that's one that I didn't send to have any more imaging done only because I was worried about them moving the unstable head around in radiology. But otherwise, you really want to have a plain film for every patient so you know what you're looking at as you go into the OR. The number one wrong site surgery, many of you know this, is wrong level surgery in spine. And if you look at the reason for wrong level surgery in the spine, this has been looked at a couple times now, it's the surgeon misinterpreting the intraoperative imaging. And so one of the ways to prevent that is by making sure you've looked at the films and that they have films beforehand. Finally, we're going to end our last couple minutes here with what makes a good image or a good film. And a little bit kind of back to basics here, but I think it's worth reviewing and talking about. So when you look at the cervical spine, what are the things we're looking at? Again, this isn't going to be everything, but it's certainly a place that folks can start. And so certainly there's the lines that you can look at, your anterior and posterior vertebral line. You can certainly look at your spinal laminar line and your posterior spinous line. You can also look at your AP. And when you're looking at your AP, you want to make sure that your spinous processes are midline, right? And so that's an easy check you can do to make sure you're actually looking at an AP and not some oblique. And so here's a fluoro shot from the OR, and at first glance might look okay, but if you look carefully, you'll see the spinous processes are all out here on the side. And so clearly rotated, get another one where they're centered, and you have a much better image here. Same thing with the facets. You want to be able to look kind of like this film here. You want to be able to look across those facets and see down that joint really on both sides to make sure you're lateral. And so if you look here, you'll see a series of images, fluorospots trying to get them to look down the facets. But you'll see here the facets are way off, right? And so you can tell that there's a space here, space here. I mean, nothing's lined up here. And then as we rotate the machine, we're getting closer here. And now you can see that the facets are lined up right here and here, right? So you see this space completely through the facets, which tells you that you're in the right spot laterally. And as you can see, that changes where your needle is, and it changes where you think you're going as that gantry changes. So it can lead you to the wrong spot. Again, lateral C-spine, looking at the facets again. So here's a shot showing lateral mass screws. These all look like they're well in the facet, but down here you can't tell, right? So you have to wag a little bit, change your angle. Now we can see you can see through that facet, you can see through this one. And this was a patient that happened to get a CT, I think for other reasons, post-op, and you could actually see everything was where we wanted it to be. You could always spin an O-arm. I think I have a little hard time spinning an O-arm and spending that time if it's just going to be lateral mass screws in the case, but you could certainly can make the case for that. So you want to make sure it's lateral, check the facets. Technically, a good lateral C-spine should include down to C7, T1. You should be able to see that disc space. Oftentimes it should, although it may not always, indicate whether they're seated or standing. So here you see a sitting upright. That's good. And then I would say that it should include, you oftentimes want to, in your imaging at least, include all the hardware that's in there, right? And so in this case, if this was all they got post-op, you'd say, well, get another view to make sure we see everything, see where this ends down here, which they've done here. All right, what about your thoracolumbar spine? There are things you can check here as well, right? So you can check your iliac crest, which you can see here. I'm drawing on it with my mouse if you can see that. And you want to make sure they're roughly, ideally they'd be overlapping. You want to make sure they're in the same ballpark. You can look at the femoral heads. You can see both of them here. You can look at the sciatic notch. You can see both of those here as well. So this is not a bad lateral. It's not perfect, but it's not terrible. Here you see post-op similar. The notch, the crest, the heads, they're all kind of in the same ballpark. But then here's one from follow-up, right? So this gets done in clinic one day. And this is something anyone can look at and say, yeah, why don't you try again, right? The iliac crests are a mile apart. You can't see femoral heads. I'm not sure where the notches are. It looks like this is one of them here. And so obviously this doesn't tell you anything. You can't compare anything, right, looking at this. You don't have another film that's at this odd oblique angle. So certainly send this patient back and have them get a real lateral, which is what we did. And okay, now it's not perfect, right? Here's the notches, the femoral heads, the crest, but it's in the same ballpark. You can certainly now start comparing and saying, okay, everything looks okay like it should look. Scoli films, you could give a whole talk on scoliosis films and EOS and other things, but I guess what I would say is that you want to try to encourage your patient to stand up straight for these, not leaning on their walker, not twisting, etc. And so as a patient who really wasn't healthy enough for a PSO, but we did do A-lifts above and below this previously fused block at an outside place to give her some lordosis back and decompressed her, and then really bent her back on the pro axis. And all her parameters, if you look at this spine, are actually pretty good, and she's leaning forward at her hips. And so this is a patient who was really deconditioned, got her in therapy, talked to her about the importance of getting her back strong, and she actually ended up standing up perfectly straight and doing great long term. But sometimes it takes a little encouragement for that. So to conclude, we talked about what imaging to get, why to get it, why plain films are so stinking good, and what makes a good film, at least the basics of what makes a good film. There's obviously more we could go over in a different talk. And to conclude, I'd say, CT, MRI, X-ray, all useful in different ways. We didn't even have a chance to get into things like nuclear scans or other things. I do think it's important that everyone, all providers, critically evaluate the plain films. I also think it's important that you don't just trust the read, that you evaluate them. And then, when in doubt, just get a better film. That's the nice thing about X-rays is you can send someone right back to get it. It's not a whole nother study or a whole nother day that they're waiting. Make sure you have the right film, particularly if it's an operative patient. So I will stop there. It looks like we've made our time, and I'm happy to take any questions if there are any. Well, I don't see any in my chat, and I don't see any raised hands, I don't think. So uh, I am certainly okay to end there. I want to thank everyone for joining us, particularly on January 2nd, when I know a lot of people are out and a lot of people are traveling. And certainly happy to answer any questions via email as well, Matthew L. Goodwin at gmail.com. And onward and upward. Thanks for joining, everybody.